Welcome to part 10 of this series of slideshows that describes the mammalian stress mechanism that was predicted by Hans Selye. This presentation will explain the turbulence mechanism that regulates diastolic arterial turbulence in accord with autonomic balance. Mammalian physiology combines systolic laminar flow efficiency with diastolic turbulent cleansing to simultaneously optimize exercise capacity and atherosclerosis resistance. The heart effortlessly expels its contents in a fraction of a second as cardiac contractility is converted into pure, friction-free kinetic energy. As blood velocity declines during diastole, red cell aggregate formations suddenly disintegrate. This instantaneously converts the kinetic energy of flowing blood into a turbulent pulse wave that propagates towards the periphery. This traveling turbulent wave halts blood movement, mobilizes particulate deposits from the inner walls of arteries to prevent atherosclerosis, and generates lateral forces that enable blood pressure measurement and the palpable pulse. This graph illustrates the dynamic relationships between blood flow velocity and aortic blood turbulence in a dog. The cardiac cycle begins with a period of isovolemic contraction where pressure within the ventricle rises above a threshold that causes the aortic valve to open, whereupon systolic ejection accelerates blood velocity from 0 to 125 centimeters per second, and blood surges throughout the arterial tree until the heart expels its contents. This happens in less than a tenth of a second. During the following tenth of a second, turbulent flow resistance appears as the velocity of speeding blood declines and the red cell aggregate formations deteriorate. As velocity declines below a critical threshold, the aggregate formations disintegrate, and the kinetic energy of the speeding blood instantaneously converts into a burst of turbulent energy that halts the forward flow of blood as it travels towards the periphery. In this particular example, where the measurements were obtained in the aorta, there is a brief reversal in the direction of blood flow. This occurs when the cardiac muscle relaxes and the cartilage skeleton of the heart causes the ventricle to expand and draw the aortic valve shut. Systole is thus complete within 0.2 of a second. The brief flow reversal initiates a pulsatile wave of turbulence that propagates rapidly throughout the arterial tree, halting arterial blood flow as it moves. The efficiency and brevity of systolic blood propulsion has been persistently overlooked. The weak forward force that propels blood cannot be measured with conventional equipment, and arterial turbulence appears only during diastole after the ventricle is at rest. Diastolic arterial turbulence is analogous to pipe flow turbulence. The turbulent pattern is potentially affected by temperature, cardiac contractility, arterial length and diameter, red cell mass, bifurcations, and imperfections. But mammalian physiology normally maintains all these parameters within narrow ranges. Cardiac contractility varies little from beat to beat, so that each heartbeat produces a brief burst of intense turbulence that mobilizes debris from the inner walls of arteries and optimizes atherosclerosis resistance. The turbulence mechanism generates and disintegrates insoluble fibrin in accord with autonomic balance in the same manner as the capillary gate mechanism that was described in previous slideshows, but its effects occur in flowing blood rather than on the inner walls of capillaries. It releases von Willebrand factor from the vascular endothelium in accord with sympathetic tone and activity to activate factor VII and generate insoluble fibrin. It releases nitric oxide from the vascular endothelium in accord with parasympathetic nervous system tone and activity to disintegrate insoluble fibrin. It regulates the equilibrium of fibrinogen, soluble fibrin, and insoluble fibrin in flowing blood. The turbulence mechanism regulates insoluble fibrin in flowing blood, where it entangles red cells, disrupts red cell aggregates, induces systolic turbulent friction, and reduces end-systolic velocity. This alters diastolic blood turbulence so as to exaggerate blood viscosity and coagulability, and undermine cardiac efficiency, decrease cardiac output, elevate blood pressure, increase pulse rate, and accelerate atherosclerosis. By exaggerating blood viscosity, the turbulence mechanism reduces peak systolic velocity, which alters diastolic turbulence in favor of increased lateral forces at the expense of turbulent mixing. The increased viscosity also reduces ejection fraction, causing a compensatory increase in heart rate via the Starling mechanism. These relationships explain why sympathetic activity causes tachycardia, hypertension, and decreased tissue perfusion. Blood pressure is a misleading guide to therapeutic intervention because the relationship between blood pressure, tissue perfusion, and cardiac performance is unreliable. Pulsatile turbulence varies in accord with arterial diameter, curvature, and bifurcations, so that its intensity varies from location to location. Blood pressure cuff width and patient anatomy perturb blood pressure measurement. Invasive arterial cannula transducers must be calibrated in accord with cuff pressure. Regardless of how it is measured, blood pressure is only indirectly related to cardiac contractility, cardiac output, tissue perfusion, and tissue oxygenation. Multiple variables affect the turbulent forces, including temperature, red cell mass, and blood viscosity, as well as cardiac contractility. Brain-damaged, bedridden patients often survive for years without developing atherosclerosis, but inadequate blood turbulence exaggerates blood coagulability and accelerates atherosclerosis, while excessive blood turbulence undermines hemostasis and inhibits atherosclerosis. Inadequate turbulence enables particulate deposits that incite an inflammatory process that produces atherosclerosis. Blood cholesterol is incorporated into the atheroma, but does not cause it. Atherosclerosis typically appears on the greater curvatures and bifurcations of large proximal arteries where turbulence is exponentially decreased. Decreasing distal aortic or arterial diameter exponentially exaggerates turbulence and inhibits atherosclerosis. Chronic stresses due to smoking, fear, and apprehension, chronic illnesses, chemical exposure, trauma, and surgery activate the turbulence mechanism and accelerate atherosclerosis. Down syndrome mitigates fear that activates the turbulence mechanism. Anemia exaggerates blood turbulence, inhibits atherosclerosis, and undermines hemostasis. Polycythemia inhibits blood turbulence, accelerates atherosclerosis, and exaggerates blood coagulability. Hemophilia, von Willebrand disease, and anticoagulant medications inhibit insoluble fibrin, enhance turbulence, retard atherosclerosis, and paralyze hemostasis. Extreme reductions in blood turbulence can exaggerate blood coagulability and trigger systemic coagulation activity that is called disseminated intravascular coagulation, or DIC. Such activity rapidly consumes coagulation substances and paralyzes hemostasis. This usually involves multiple factors: excessive elevations of red cell mass due to transfusion with washed, packed red cells, polycythemia vera, and erythropoietin treatment all increase the risk of DIC. The release of tissue factor into systemic circulation by head injuries, severe trauma, amniotic fluid embolus, and extensive surgery can cause DIC. Turbulence mechanism hyperactivity due to hypothermia, pain, fear, and other stresses can aggravate the problem. Regardless of how it starts, systemic coagulation activity rapidly depletes fibrinogen and fibronectin as it generates excessive quantities of soluble fibrin and defective forms of insoluble fibrin. The soluble fibrin forms deposits on the inner walls of arteries, disrupts placental function, and binds to defective red cell clots to form rosette bodies that characterize the phenomenon. If the defective coagulation process reduces red cell mass below a critical threshold, excessive turbulence paralyzes hemostasis in the manner of anemia. Treatment should include control of pain, stress, and hypothermia, as well as restoration of red cell mass and coagulation precursors. This concludes the basic introduction of Celia's mechanism. If you have suffered through all the previous presentations, you must be immune to stress, and you will probably live another 200 years. I hope that these slideshows will inspire you to read my published papers, which can be obtained via my website, www.stressmechanism.com. As time permits, I plan to add additional slideshows that will explain anesthesia history, the new theory of anesthesia, analgesia and allostasis, and the unified theory of biology that is enabled by Celia's mechanism. I am also preparing a book that summarizes the implications of stress theory. Thanks for listening.